I'm so completely thrilled to be part of this amazing event today, and just to start getting connected with everybody. So thank you so much to Cher and for all everybody listening to this today. So I'm going to be focusing on the work that we've been doing for 20 years with adolescents living with HIV. They're our peers, young people living with HIV in Zimbabwe. So as I say, we started 20 years ago, and we've been evolving this over the years and really learning a lot, what works, what doesn't work. But the kind of theme to all of this is it's been young people driving the process, telling us what they need, telling us what they can do and what support they need from us. So that's going to be sort of the theme of what I'm talking about today. So we call our peer counselors, peer supporters, community adolescent treatment supporters, or CATS for short. They're friendly cats, they're not African wild cats. And so it's really this cadre that I'm going to be talking about. And really a huge focus for us over the years, for us as an organization, but also in the work that when we're talking to people about this cadre, is how do we best support this cadre? We know they're phenomenal. We know they do an amazing job. We know they can do, change the lives of other young people living with HIV, but it isn't a quick fix. And a lot of our work a lot of our time is spent on helping people understand that it isn't a quick fix, and it has to be invested in so that we make sure all the key steps are right for them to do what they can do well. So we're called Zvandiri. Zvandiri in Zimbabwe, it's from the Shona language. It means as I am. So when we first started back in 2004, we asked young people what they would like to call the first support group, which is what we started with. And they said Zvandiri. They wanted to say, I may be HIV positive, but accept me as I am. So right from the beginning, it's been a message from young people about what they need and what they want. And we've really tried to hold on to that as a sort of our daily purpose in all that we do. And here are 4 happy cats. So I'll talk through this slide. I'm going to give you obviously a background to the model, and then I'll talk about the focus of this talk, which is how we support them best. So this is really, Zvandiri is at its core peer-led service delivery. And we do this through the community services, in the clinics, and through digital. We've always had this digital component, but of course, like everybody, that's really scaled up over the last 4 years. And so what we do is we identify and train and supervise and support adolescents living with HIV, adolescents and young people. So they are 18 to 24 years of age living with HIV. And they are connected with children and other adolescents living with HIV, and they support them in the home, in support groups, through digital, through WhatsApp, through SMS, through phone calls, and in the health facilities. And they also work closely with health workers and families. So we started with 10 cats in 2009. It was just a test. It was a pilot. As an organization, Zvandiri was supporting the Ministry of Health to train professional counselors in how to support children and adolescents living with HIV. But we were still missing so much. The professional counselors were doing their best, they were doing a great job, but there was still something missing for young people. And it really was having that, what we found. And what our gut feeling was that they needed to be, as the young people were telling us, they needed to be connected with other young people that get it. And so we started with the Ministry of Health. Right from the beginning, it's always been an intervention planned and delivered with the government, because we wanted this to ultimately be sustainable. And so we started with 10 young people who were clearly very capable and competent and committed to supporting their peers living with HIV. So we started at 10. It was very quickly clear that this could really work and could really offer the health system something that was missing in the lives of kids with HIV. Today, there are 2,400 cats across Zimbabwe. Thank you, Ruth. And excitingly, the model's been adopted in 10 countries across Africa. So we're now working with, I'm leaping ahead here. I'm so excited because I've got so many questions to ask Ruth and Sarah and Selena. Hi, Selena. But anyway, I will take my time. So yeah, it's been adopted by governments across the region. And so we're really excited to see that happening, but of course, absolutely committed to making sure this is done and scaled well. And we're all talking today, aren't we, about what that looks like and what that involves. So there are cats, but we've also evolved this peer CARDA to young mentor mothers. So again, they are 18 to 24-year-old living with HIV, but they are mums. And we also have a group that are young men or dads. And so they specifically look out for their peers who are living with HIV, but are also mums and dads. Collectively, actually, that's an old number. 64,000 young people are being supported by these peers in Zimbabwe, but then we have another 40,000 in the region. So that's a sort of summary of the model. And really what we're doing is we are integrating peer-led HIV and mental health support for these kids with HIV. Really trying to ensure a holistic approach embedded within the Ministry of Health. So while the Ministry of Health is providing antiretroviral medication, all the laboratory investigations, the clinical reviews, it's now standard of care in Zimbabwe that every child or adolescent that's in a clinic living with HIV and getting their treatment is also referred to a CATS. So I tell you, Ruth, I want to fly over and see you, Ruth. I've got so many questions for you. So this is a sort of summary of the mental health response, because, you know, I think we're often presenting to a sort of HIV audience, but increasingly people are interested in what it is about the mental health. And I'm sure this is, well, I would imagine this has been a common issue for everyone involved in today, but for 2 decades, we were talking about psychosocial support and peer counseling and peer support, and it kind of fell on deaf ears often. When we started talking about the mental health work that they're doing, it seems to be attracting much more energy. And yet really, as I'm trying to summarize in this slide, what we're doing is really trying to promote the well-being and quality of life of young people living with HIV. We're trying to prevent mental health conditions, and we're trying to make sure that those that are at risk, we identify and refer them to the support that they need. So I'll just talk through that. What our peers are doing is they are sharing information and about mental health and well-being, and trying to ensure that their clients, who are children and adolescents, and their caregivers, understand much more about their own mental health and well-being. They're counseling. We have a lot of debate about the term peer supporters versus peer counselors. We are really trying to advocate for that they are trained and supervised with lay counseling techniques and strategies. And this draws from CBT, positive psychology, narrative therapy, and I'll talk about some of that in a moment. And they're doing this in the community, in the facility, health, in the clinics, and through digital support groups. Then in terms of, so that they'll have their caseloads, so the CATS will be based in a clinic, and they'll have a caseload of between 30 and 50 young people, and the caseload is something we can talk a lot about, and that has a direct link to this topic of how do we care and support our peers, because obviously some of our funding comes with an expectation that our peers have very huge caseloads, because it's about the targets, and we spend quite a lot of time pushing back on that to say, well, actually, it isn't fair on the peer, and actually they end up being overwhelmed if we're not careful. and B, they can't do what we know they can do well if they have these massive caseloads, and then they're being judged on the results of those massive caseloads, which is not fair, clearly. So we've really pushed back to try and make sure that this caseload is fair and manageable and feasible. Sorry, I digressed. So they're focusing on promoting mental health and well-being, preventing the development of mental health conditions. And then they also work on the identification response for those at risk. So they do conduct mental health screening among their clients, and they use a Zimbabwe developed validated scale called the Shona Symptom Questionnaire. And we've also recently added in a question, a component to this on the scale to screen for substance abuse as well. They identify those that are at risk, and then they refer, but they step up their counselling that they're providing. They refer to other mental health cadres, and in our context, that's sorely lacking. And so which makes an even stronger case for the role of this of task shifting of this peer cadre that we're talking about. They support joint case management and conferencing, and they also work with our Zvandiri clinical psychologists for those with severe psychiatric conditions. By the way, I can talk a lot, so please just interrupt anytime. So it was interesting to hear Ruth talking about the link between implementation and research. We at Zvandiri, I always say we're not a research organization, but we have a very firm commitment to ensuring that everything we've done is informed by research and then evaluated. So we've been really privileged over the years to work with research institutions, other researchers who have walked this journey with us, and collectively we've got a sort of huge body of information and evidence for what's needed and what works and what doesn't work. We've conducted randomized trials, but also operations research, implementation science as part of this process. And some of this work has always focused on the lived experiences of this peer cadre and the cats. And we've used this to make sure that we're always looking out for what their needs are and to inform the Zvandiri model as it's evolved over the years. Here are 2 papers. There's another one. These specifically focus on the needs of cats in providing support for their peers. But we've also conducted 3 RCTs evaluating the model. I can share any of this with you if that would be interesting. We love participatory qualitative studies. Sorry, randomized trials, controlled trials.
Okay.
I apologize. So yeah, there are 3 randomized controlled trials that have confirmed that young people in Zvandiri, supported by peers, are much more likely to have a suppressed HIV viral load, and that they are much more likely to have better mental health. So I can share those with you. People often say, oh, it's great you've done all this research. And I think, based on what I've already heard from Ruth, I think I should add, we didn't set out to do lots of research. We really wanted to focus on getting the work done with the kids. But we had to do the research because no one really got what we were, well, some people understood what we were trying to do, but getting the money to support it was different. And frankly, we'd done some nice, what I think are wonderful, qualitative, really important studies. But what we had to do, certainly from an HIV perspective, was show that what we were doing had an impact on biomedical markers. It's been much, much harder to prove it, to make a case for this based on mental health until more recently. So our first randomized control trial was actually to show that young people supported by peers had a better viral load. suppressed viral load for HIV. And that really helped to generate an understanding that this 18-year-old peer living with HIV could have a significant impact on the HIV epidemic. And so that was really important. And then a more recent trial we conducted looked at the mental health of young people supported by peers in Zvandiri. And we found that at the beginning, 68% of adolescents living with HIV were at risk of depression and anxiety. We say at risk because we weren't diagnosing, we were screening, but 68% were at risk. And after 12 months of being supported by the peers, the CATs, only 2% were at risk. So we were thrilled because, you know, for all of us, we're trying to champion this role of peers. And then we've got this really solid empirical data, just confirming what we all know and believe, like we've started to talk about, Ruth. We believed this and we saw it every single day in the lives of the kids we were supporting, that this works. But the trials were important for strengthening our case. So some of this work, as I was saying, has focused on what the needs, sorry for the typo in the sentence, in the title, what the needs of our peer counsellors are. And we love participatory methodologies. We use a lot of body mapping. I personally used body mapping for my master's. I looked at the lived experiences of young people with depression and HIV, and we used body mapping, and it was phenomenal for them to share their experiences using colors and pictures and paints. And but this and we've also used digital stories. This told us a great deal about what peers need when doing this work. So here are some of the there's one of the paintings from one of the body maps. But here are a couple of quotes from the cats. They said, the first one is Rudo. When I became a cat and seeing others, this gave me strength that even if I wanted to default from my medicines, I should know it's my own life being affected. From then, it has helped me to know that medication should be taken correctly and on time. So we found that when the cats are supporting their peers, it's also helping their own self-efficacy, their own self-confidence, their own self-care. And I'm sure you see this over and over again. And the second one confirms this. There is also empathy that I felt for the participant, considering the situation I faced before when my viral load was very high. So his viral load, his HIV viral load used to be high, and now he's saying, I will be in the shoes of my participant. I try and open the eyes of my participants so they can see and encourage them to try so the viral load can go down. So it's this sharing of lived experiences that we know resonates so powerfully compared with any of us, particularly for kids and adolescents. You know, I mean, this is my daily bread. We love this work. But at the end of the day, I'm old. I'm not a 16-year-old from Zimbabwe. So at the same time, and I'm talking about the personal and professional challenges in this particular talk, but at the same time, we know this work brings enormous challenges, potential challenges for cats. So they talk about feeling overwhelmed. This young, I think it was a woman, she said, when discussing with my clients about their problems, it is difficult at times, but as a cat, I am not supposed to be overwhelmed by it, as I'm supposed to help the beneficiaries in their various problems. So this sense of huge responsibility for getting it right for their clients. And whilst I was saying that we see a lot of tremendous impact on peers in terms of confidence and self-efficacy, self-worth. The risk also is that they bear this sense of responsibility for their clients and what happens when that goes wrong, so to speak. So particularly when if if their client isn't doing well, or if their client passes away, or if they put in all this effort to support their client and the client still doesn't take their medication, what's the impact of that on them, and them taking it very personally? And we all know that, don't we, how that can feel. But when you're 18, 19, 20 and working really hard to get it right, and it still doesn't quite work. We also find, of course, and I'm again sure this is what everyone is talking about today, that the power of the peer, of course, is well, one of them is the immense sense of understanding and shared experiences. But that can also be a risk because it triggers, the cats have so many of the same experiences. So when they're supporting their clients, they're hearing over and over again similar experiences, and that can trigger them. And this young person said, there are problems like those which they say they lost their parents. For me, it will be touching, as I also don't have parents. I lost my father. So if a person comes talking about losing parents and then cries, these kind of situations I won't be able to handle. So what are we doing as an organization to help them manage these triggers? Another one, similar one, the participant sadly passed away after a lot of work had been done which affected me. I need counseling to come to terms with his death. So that's what I was speaking about earlier. How do we help them to manage when, despite working incredibly hard and putting their life and soul into supporting their peers, it doesn't go well? Need for support. I think there's need for us as cats to be supported like what we do for clients. So in Zvandiri, we say our first primary client are the cats. So yes, they are the peer cadre that are supporting other young people. But for us, our primary focus is to make sure we're supporting the cats fully for their own personal needs, their own well-being. This is written up in a published paper, but one which we came up with this framework called the Trust Framework, which was really coming out of what we were hearing from young people about their needs for support. And so I'm going to talk about more of this in a minute, so I won't dwell on this. But it's really about getting their training right. It's about having an established referral pathway, so they're not identifying all these needs in their clients and then they've got nowhere to refer them to. So a huge part of what we do before we start this intervention with cats is make sure that everyone they're working with understands their role and that there are clear referral pathways so that when they identify their client has a need, they know what to do and where to refer them. This is particularly important when we're screening, when they're screening for mental health conditions. It would be clearly horrific for them to be screening and finding young people who are depressed, for example, or suicidal, and they've got nowhere to go. So that would be terribly wrong for the client, but also for the cats when you're leaving them with this burden of identifying a need that they can't address. As I was just saying, we work hard on ensuring, we've invested a lot of time in ensuring that the health system, or the community system within which cats are working really understands the role. When we first started this, there was a bit of a risk that the cats were perceived as being there to make the tea or to pull folders out of filing cabinets, etc. And if you can imagine, I don't know if you've been to Zimbabwe or anywhere similar, but the idea years ago that an 18-year-old living with HIV might be considered as a valuable member of the healthcare team, that seemed quite alien. Whereas now, it is truly humbling and heartwarming to go into a clinic and hear the nurses say, in fact, this happened to me a few weeks ago, one of the nurses said, the cats are our eyes and our ears, and we could not do what we do without them. So they are, because often in a clinic in Zimbabwe, we might have one overstretched nurse who's managing the whole community's health issues. And so to have someone that is really well trained and supervised, who can really understand and relate to the pediatric and adolescent population in that clinic is invaluable. Supervision. We'll talk about, I've heard Ruth mention that already. And recognizing that if nothing else, talking helps. And often we feel this sort of an expectation to prove many different layers of impact. But actually what we're also saying is, if a 10-year-old has a peer to talk to who knows that journey with HIV, if talking and listening alone is what they do, that is impactful. And that is what we hear over and over again. Having someone there that listens, that gets it, that is there to talk with them, that shows they value and validates their experiences and helps them to get to other support. That's where the magic power lies. So I can't see my clock, and I know I'm a talker. So am I all right for time? And I really don't want you to have to just listen to me. I want to have a conversation. So
really, it's 9:30 our time.
Is it?
So
Okay.
yeah, so you're a half an hour in.
Okay, so I'm going to push through these, so then we can have a conversation, if that's all right. But as I say, just interrupt me at any time. So this is really a summary of the steps of our take on how to best support the peers. And I can't wait when I'm done to listen to all the other sessions today and the recordings next week, so I can learn on how we can improve this. But I'm just going to, these are a summary, and then my next few slides talk through these different steps. But in summary, we spend a lot of time selecting the right people. We really invest in their initial training, but we acknowledge that initial training, which is 5 days, is purely the tip of the iceberg, and that really on-site ongoing training is key. We try to ensure that we are paying them as an allowance, and I'll talk about that. They get tools for the job, so a bike. A lot of the cats work in very rural, remote areas. We don't give bikes to cats in towns, because if you've ever been on a bike in Zimbabwe, you know it's a death wish. So part of caring for the cats is that we don't put them on a bike in a town where they might very quickly get knocked off. So they get extra money for going on the bus or whatever. They have data, airtime, have a phone. We have a whole range of issues with connectivity and data. And, we often we've got a very basic app we're trying to improve at the moment, which has all their tools on it. If only internet connectivity was better and they could be streaming things, it would make life very exciting. But we are quite limited in what we can do there. So ongoing on-site virtual mentorship and supervision. And then what we call cats care, which is really looking out for their own health and well-being, making sure that they are taking their medication, that they are getting their viral load monitored, their regular blood tests. Sorry for the acronym, that we're looking out for their sexual and reproductive health needs and services, and that we're looking out for their mental health. But I'll talk about that in a moment. So there's lots of words here. I will summarize. When we're selecting cats, we always do it with the Ministry of Health and Childcare. They are 18 to 24-year-olds living with HIV. They're HIV positive, and they know their HIV status, which might sound really obvious, but you wouldn't believe how many 18-year-olds on treatment still aren't being told that they've got HIV, because there's so much stigma around families sharing that. That's a whole other topic. Ideally, they're taking antiretroviral therapy. They're doing well. They're not in school, and that's because we don't want this to interrupt their schooling. That they're comfortable talking about their status to their clients, that they are committed and passionate about doing this work. And again, that might sound obvious, but we've had some incidences where the family really want their child to be a cat because they'll get the monthly allowance. But it isn't really what the young person wants to do. So all these things we need to, really take care of. And interestingly, when we've worked in other countries, And we've really emphasized this point that it's a very careful process we have to invest in, and that the young person is ready and really wants to do this, rather than it being put upon them. And sometimes it gets rushed, and always the country comes back and says, oh, now we get it. We realize you were right. We need to take time in selecting the right people. They need to be able to read and write. Again, it might sound obvious for an 18 to 24-year-old, but sadly, we do have our education system is challenged currently, and we do have young people where that may not be the case. We've tried not to exclude people where they struggle to read and write, because we don't want this to limit people. Having said that, we found that the reporting requirements and just documentation is so challenging. We're kind of not really being fair on young people if we don't if we take them and they struggle. We've tried everything. We've tried making our report forms lots of pictures and symbols, but it really is a struggle when your funders need reports. And the caregiver needs to give a consent. So again, they're 18 to 24. You could argue they're adults, they don't need to, but in our context, they're living at home often, financially dependent on that household. And if they start coming home, or they disappear off, and they say, I'm going to the clinic, and they come back with a bit of cash, or they come back with a bike and a phone, and the family like, where's that from? And this family is desperately in need, with high rates of poverty, and the caregiver doesn't understand the role of the peer, then it can be a conflict. So caregiver, maybe I should say caregiver gives assent or agreement or concurrence, something like that. The training, there you are. Some of the cats are being trained there. That's clearly from COVID days. So it's a 5-day classroom-based training. We've tried and tested this since 2010. We've evolved it. We've developed it with the Ministry of Health and Childcare. It's classroom-based, but then we make sure that they are supported over 1 to 2 weeks, being inducted into onboarded into the health facility. And we use, as I say, a training curriculum and mentorship books. I'm going to speed up a little bit. Supervision and mentorship. There's lots of acronyms here. I'll speak to them. But it's conducted by the healthcare workers in the clinic, together with the Ministry of Health provincial team and the Zvandiri team. So we have a multidisciplinary, multi-sectoral team that come together to support the supervision and mentorship. We take it really seriously, and we have to fight hard for the money to do this. So we often have people who say, oh, we've got a bit of money at the end of the year, can we train some cats? And we'll say, well, it doesn't really work like that. It isn't just about a 5-day training. It's really about building a system within the healthcare team that understands the role of the cats, that is ready for them, that supports them so that they are supported to do what they do well. And then the ongoing supervision, as I say, it's a team that goes out and really supports and monitors how they're doing. And this can be observation, but it's also guidance on how they manage their caseloads, how they do their documentation. Yeah. I'm going to probably skip that one. And then CATS and YMM is the Young Mentor Mothers. So it's conducted in a district by the Zvandiri district team. And as I summarized earlier, we're making sure they get their viral load checked, because we often find the peers are so invested in supporting their clients that they forget their own health. And so similar, the second point on TB, we found 1 year we had 20 deaths from TB amongst our cats. This was about 6 years ago. And obviously TB is a cause of considerable mortality in this population in our context, but clearly that was unacceptable. When we then formalize this cats care concept, we work with the Ministry of Health to make sure that the peers all get this package. And now we have, I think we had 2 deaths from TB last year, which is clearly too many. But just by making sure there's awareness of what this peer CARDA needs, and that we are prioritizing their health and their well-being, we are ensuring that we're picking things up and preventing problems later on. Same the mental health screening, we're doing that twice a year, unless there's indications for more frequently. We're checking on their sexual reproductive health needs. Do they need family planning? Are they having any challenges in accessing services? Young people going to a clinic, maybe it's the same where you are, but young people going to a clinic to ask for sexual reproductive health services is a huge challenge in our context. They don't want to go. They fear rightly fear a common reaction, which is why you're asking for sexual reproductive health services. So supporting them to access that is really important. Same for cervical cancer screening. We've just done some work with our young mums living with HIV and found 40% of them had a positive HPV test. So, yeah. So, and again, we went rogue to do that. Normally testing isn't done under 24 years, but we believed there was something missing and we should explore. And so now we're using that to, and the peers, so the young mentor mums were talking to all their clients who are other young mums about cervical cancer screening. And the mums were saying, no way, I'm not going to do that. They hated the whole idea. But the young mentor mums really worked with them and supported them to go. We found this high level of results, but it's a wonderful example of how the power of the peer again in ensuring that these young mums did in fact access cervical cancer screening, which there was no way they were going to do before if it was me saying, yes, you should go and get a cervical cancer test screen. A big part, these are young people, they're 18 to 24. We need to accept and acknowledge that they are evolving, that they're moving into adulthood. We have to often explain this to funders who are understandably surprised that we've lost cats and we have to train more. But in our view, it's a success because they should be moving on in life. And I think when you work with a youth peer CARDA, it's a cost of the intervention, because if we have, which is what we find, if we have enabled them to move on into the next stage of life as young people, then that's a success. And we see so many wonderful results of cats who had given up on life, had no value in their home and in their community, no perceived value, self-stigmatized, who are now married with children, and their children are HIV negative. And many of them have now gone on to be employed by the Ministry of Health as counsellors, as nurses, as lab technicians, and other implementing partners, other NGOs are now employing them when they're looking for an experienced community CARDA, which is wonderful. When we look at the mental health of this CARDA, the number one challenge, apart from will they have relationships, will they get married, is economics, and will they get a job. So we do, where we can, link them up with income generating projects or help them to start their own, but also helping them to connect them on this. Being a CATS has proved to be an incredibly helpful career pathway because it helps them to then get on the ladder. And then counselling each other. So they may be the peer counsellor, but supporting them to buddy each other. We have a whole range of books and tools and animations that we develop for kids and young people living with HIV. They're all on our website, but I can share the links to any of those, which the CATs use to counsel and support their peers. And that is it. That was a lot. And you were both wonderful at listening, very attentively, and to Maddie the dog.
Well, thank you very much. That was so interesting. So tell me, the quick questions I've got are, um, you give people stipends. What's your stipend and how does that work?
Yeah. Yep. So we had a tricky one on this because it was always tricky. We started with 10 cats, like I said, and now we've got 2,400. So, and we always wanted this to be something that was sustainable. We also we had a clear message from the ministry, you know, we needed this to be something that was locally acceptable, but also fair. So they get, at the moment, they're getting 50, well, it depends if they're in an urban setting or in a rural setting, but they get anything between 20 and 50 US dollars a month, which to us doesn't sound a lot. They do get a top up, they get extra money for attending meetings and for bus fare and for their data and airtime. We would love to do more. And it's a constant battle. We have different funding streams, and some will say, you should pay them more, and others will say we can't pay them more. And so we have a challenge in terms of equity and standardizing. And I would love to hear more how everybody is managing this. Ideally, our goal would be that they would be a formalized, paid CADA. And what's very exciting is Zimbabwe is, I think, the only country, or the first country, to actually start using its own domestic funds from government tax. So tax generated by the government is now being used to pay the cats their monthly allowances. So it's that, we often hear peer interventions aren't sustainable. And yet here we have a country like Zimbabwe who is actually not only, they've put their money where their mouth is, they've not only committed to and showing that they value this card, they're actually paying them. So there's no simple answer, Ruth. We'd love to pay more. We need to strike a balance between it being a sustainable community intervention. We have other government peers, like adult village health workers, for example, who don't get paid, who don't get paid that. We have another card that don't get paid anything. So we're trying to juggle that.
I think we can help you out with more peer tools for you.
Please.
There's a thing on the share peer kit later on that you might want to go to, or at least watch next week. And also the whole selection process. I mean, I think that's something that everybody has to deal with, because it's not just that you're HIV positive and aged 18 to 24. It's
exactly,
you've got to find the right people and how to do that, and what makes that work.
We'd love to hear from all of you as well on your experiences around that.
We use scenarios. What we do is we give people some scenarios to answer. Brilliant. And then we train them for 2 hours. Just, come to a group interview and we'll talk to you about what we do and how we do it. And then we give them the scenarios back that they did to see if they change anything.
Brilliant.
Because that lets me know that they're willing to take input. Right. And that they can learn something. And then we give them new scenarios, including the one that we use is the woman coming up to you and saying that a man has slapped her on the butt. And we tell them during the 2-hour training that they are going to, that we're going to ask them how they handle the situation in the next set of scenarios. And the idea here is to be non-judgmental, to support the woman, but also to not just assume that the man did it.
Yeah.
And that the same message can be given to the man about how awful it is for a woman to be hit on the butt, whether or not they admit to doing it or not. If they don't admit to doing it, you can say, oh, I am so glad that you understand how awful that is for women to be slapped on the butt, blah, blah, blah. And then seeing whether they can get that nuance, that they're there for everybody involved in the situation.
You're assessing so many things there. It's really clever.
Thank you.
Yeah. Thank you. Thank you for sharing. I will take that back and we'll see what we can do.
Sarah, Gary, and Selena, do you have anything you want to ask about?
I would be curious to hear about, I think it's so good that you're doing those screenings with your cats, in terms of mental health and physical health, because they are still a part of this, vulnerable population, even though, they're in this position of, being employed and whatnot. I'm curious what you've seen in terms of like the mental health outcomes or like the mental health screenings with them. Are prevalence rates like similar to that of the general population, lower, higher? I'm just curious on what that looks like for their mental health experiences.
Sure, thank you. Great question. Much lower. I mean, I think by being a CATS, firstly, they're much more engaged. I mean, we are constantly interfacing, they're getting lots of support. It's much easier to, our district teams really know them incredibly well and are constantly connected. So they get to know their stories and their experiences, and are able to pick up much more quickly where there's a challenge or potential challenge. And so, like I said, in the general population of young people living with HIV, we've been finding rates of 65 to 68% of young people at risk along the continuum of distress through to common mental disorders. In our young people supported by CATS, we are finding sort of 12 to 14% on a monthly basis. In the CATS themselves, it's much. Now you've caught me, Sarah, because I can't remember the actual statistic, but it's minimal, sort of 2 to 3%. What we find with the young people we're working with, it's very much sort of cyclical. It fluctuates, and it's really about having a safety net at their point of need if there's a sort of trigger or a crisis, and having the network of CATS means they get there much more quickly. But your question is about the CATS themselves, and it's very, very low, the issues, but I will come back to you with a very concrete response to that. Thank you. Anyone else? You've all been so wonderful at listening and engaging. Thank you.
I love your trust thing. I've got that. We're implementing that tomorrow.
Oh, nice. I like that.
And we've never, we do a lot of referrals, but we haven't had referral pathways, and the idea of coming up with like a flow chart of where you go for what would make our stuff a lot better. And
well, that links nicely back to Sarah's question, because the research we did found that a real point of tension and stress and anxiety for the CATS was when they didn't know what to do with this challenge that they'd identified. And so, and again, going back right back to the beginning of what I was saying about this sort of feeling that immense burden of responsibility for their clients, as we all know ourselves, don't we? But as kind of empowered adults, you can say, well, we'll usually find a way or know where to refer someone to. But we also know what that's like when there isn't someone to refer to. So that's really a tension point for them. And so by having a very clear pathway of when there's a challenge with this, who do they go to, and ensuring that that referral point knows they might get referrals is really, really important, so that we don't create a demand for services that aren't there. And that's particularly a particular challenge in our context. As I say, we have 12 psychiatrists in the country, if that, and a population of 12 million, I think. So it's about one psychiatrist to a million. And then the psychologists, there are many, but it's a real challenge, and particularly for child and adolescent psychologists. So there's a huge gap, and if we don't get those referral pathways right, it can be a huge problem. Anyone else? As I said, and we've got lots of resources on our website in terms of tools. They are, of course, based on the Zimbabwean context, but I think many of these issues are common to all young people, and importantly, they're developed with young people, with peers for other kids. So the peers are been very involved in developing, writing all of these things.
Can you give us your website? Oh, sorry,
Of course.
It's okay. It's okay. There's a question posted in the chat, and from Sierra. She's having, the mic issue. So she just wanted to know, how many years has this program been around?
Sure, 20. So we started in 2004 with 6 adolescents who said, basically, we need modern medicines. So they said, it's great we're getting antiretroviral medicines into Zimbabwe finally, but we need more than that. They said we need a place to come together with other young people. So that's why I wish I'd known Ruth and you all 20 years ago. So they said, we need to be with other young people. So, this is all based on them telling us what they need. And yeah. So 20 years. Of course, it's evolved. We started with 6 young people. It started as a support group in my garden. We had nowhere else. And then it kind of grew to 2 support groups. And then a few years later, we said, well, why don't we try with this peer cadre? And that was in 2009. But there's a lot of stuff on our website. But please also, I'll put my email address in. If I can help with anything, or I know I'll be reaching out to all of you, then that would be wonderful. And I should also just acknowledge my colleague Carol, who would also have been here, but she's on another conference today. And we have, I think if we ever do this again, I should absolutely be here with one of the peers themselves who could be speaking about, who could do this presentation far better than me. So next time we'll have one of the cats talking.
That would be wonderful. We'd love to have that.
Yeah,
and we'd love to hear more about your supervision as well at the supervision conference, because that's also
wonderful.
That's also a big issue, that the peer stuff a lot of people are doing, but the supervision is much harder to come by, and is being grown at another, is that way far behind the peer interventions at this point.
We'd love to, Ruth, and again, love to learn from all of you on that as well. And we found, this sort of this suggestion that peer equals cheap, and peer equals cheap equals quick results for no money, and therefore advocating a budget line for supervision is kind of, what do you need that for? So we could share some frustrations and some thoughts and what we've tried on that. but as you're saying, it's just, I actually say, as an organization, really what we do is supervision. It's what, if you boiled everything down, yes, we have to find the right people and train them well, but really after that, it comes to supervision. And we are still learning on how to get it right.
So what sort of issues do you have with supervision?
Oh, sorry. The first is, frankly, we need it to be resourced. We need it to be funded so that we can have enough people in place to provide it. It's as simple as, apart from, before we even get to what does supervision look like, we're talking about, we've embedded an 18, 20, 22-year-old into a clinic with one nurse or two nurses, but those nurses are completely overstretched. So in an ideal world, our goal is that we work with the nurse to provide the supervision for the peer. But really, is that likely? We are testing it in Zimbabwe. We're testing a more hands-off approach where we're providing support to the ministry to do the supervision. But in reality, that nurse is completely overstretched. And so it's really, before we get to anything, is about having enough bodies and trained people who know what supervision should involve and what that looks like. So then it's about, if it isn't someone in the health facility, is it an external person, and who that should be? And then it's really, again, about logistics. How do you get them to the facility, to the clinic often enough to provide meaningful support? We have, of course, like everyone, toyed with models of doing this virtually. But virtual for us, as I mentioned earlier, connection, internet, electricity, power, they're all such challenges. So, ideally, we would try and get people together. So what we do is we have a combination of, in the clinic, where we have someone going to provide to do work on the supervision. We use a lot of case-based approaches. So Ruth, you talked about scenarios. We have a lot of, every CATS will have their caseload, and we will talk through caseloads and use that either one-on-one supervision or in groups, because we find the groups really, really helpful. It can also be a bit less intimidating for the young peer, where they actually share and learn, and we find that quite empowering as well. Well, they'll look at different scenarios and how they've handled those, and we use those cases to talk through some of the technical content, but also their skills and how they've been able to respond or challenges that they had. So it's a combination, but the main challenge is getting who's going to do it and how often and where.
So we've just implemented in the last 2 years where we take our better peers,
yes,
and use them to supervise 10 of their, we call it, that we're doing this with the peer bridgers in our housing program. So we have somebody who's really good at this, who then supervises 10 people. They meet once a week via Zoom, but if you're regional, you might be able to meet, to have groups that can get together, and then any problems that come up, the supervision is then done of the supervising peer, who then learns how to supervise down below. But that makes it possible for supervision to for everybody to get good supervision.
Yeah.
Yeah. And when there's a really big issue, we can have a supervisor from up above come down. But we're all peers to begin with. But what we found is by promoting the people that are really knowing how to do it, they can handle most of the problems that come up.
I think you have just hit on a key next step for us, because I said we've got 2,600 peers. Clearly, we can't be supervising, and we need a cascaded model of having those different layers. And it would be, we do have CATs. I said they're in 10 countries. We do have CATs who come together on Zoom for peer supervision, and it's sort of coordinated by we call them an expert CATs. But that's essentially what they're doing. What would be really wonderful to learn from you and others is that model of training the senior supervisor to supervise the supervisors.
Yes.
So, did I get that right? Yeah.
Right.
Yeah, it's like the master training, isn't it?
Right. We haven't figured out how to train people like us yet.
Well, that's the problem. Yeah.
I mean, we're getting there, trying to figure out the different things that are going to happen and how, and coming up with what questions you need to ask and how to figure out what's going on and go from there is really quite something. Yep.
We've just researched and piloted a thanks, Sarah. Be in touch. A self-stigma intervention for cats to administer or to deliver, and that's heavily reliant on solid regular supervision. And we did this of getting those that did it the first time, then training them to supervise their peers doing it. And it was phenomenal and really heartwarming to see what they took up with quite success. So I'll get some more insights on that, and it would be lovely to talk more with you on that.
Yeah, I'm looking forward to getting to know you.
Likewise. Thank you, Ruth, and thank you, Gary and Selena and Sarah, and to share for this opportunity.
Thank you.
Thank you.
I'm sure I've overstepped my time. Yeah. Thank you so much, Ruth. It's a pleasure to be connected.
Okay. Take care.
Good luck with the day. Bye-bye.
Yes, you too. Bye-bye.
Thanks.